Welcome to the AOA Future in Orthopedic Surgery podcast series. This AOA podcast series will focus on the future in orthopedic surgery and the impact on leaders in our profession. These podcasts will focus on the vast spectrum of change that will occur as the future reveals itself. We will consider changes as they occur in the domains of culture, employment, technology, scope of practice, compensation, and other areas. My name is Doug Lundy, host for the podcast series. Joining us today is Dr. Karl Koenig. Dr. Koenig is executive director and an adult reconstruction surgeon at the Musculoskeletal Institute at the University of Texas in Austin. He completed medical school at the Baylor College of Medicine, his residency at Dartmouth-Hitchcock, and his fellowship in adult reconstruction at Stanford University Medical Center. He also has a Master of Science in Evaluative Clinical Sciences from Dartmouth Institute for Health Policy and Clinical Practice, where he began his work on patient outcomes and cost-effectiveness research. Additionally, Dr. Koenig is an associate professor and serves as both Division Chief of Orthopedics and the director of the Joseph Miles Abel Clinical Fellowship in Orthopedic Surgery for the Dell Medical School Department of Surgery. Thank you, Karl, for joining us today.
Well, thanks, Doug, for that kind introduction. I'm certainly interested in the future of our profession and excited to come and talk with you about some of the things on the horizon.
Very good. And you and I have known each other quite a while through the Council on Advocacy and our interests in healthcare policy and such. And today we're discussing the future in orthopedic surgery, specifically as it pertains to changes in Medicare shifts. So let me just get this started. Overall, how do you perceive Medicare changing in the future as it pertains to healthcare in general and in orthopedic surgery specifically?
Well, sure. I'll let me give a crack at that, Doug, and then you redirect me if I get a little off down a tangent. But I would say, it depends a little bit on the level at which you view things. So in the 30,000-foot view, I mean, there's clearly a push from Medicare to start trying to change the payment system to be a little bit more involved in more cost-effective care, trying to deal with their budget issues, which are just going to get worse and worse. And as a person who's dedicated to healthcare transformation, I mean, as an American physician, I'm frequently embarrassed that we spend so much more per capita on healthcare and yet have mediocre key indicators of health outcomes as a nation. And there's a lot of reasons for it, and there's a lot of things that can be improved. But I think a lot of it, or at least in my belief system, is that the payment system can be adjusted in ways to improve that. And so I think a lot of the work that Medicare and CMMI are doing is trying to embrace the idea of value-based care, the idea of pay for performance, the ideas of adjusting the reimbursement system. But at the same time, we don't want to lose the baby with the bathwater. And so we don't want to go all the way over to a system, with long queues to get your medical treatment and some of the other issues we see in other nations. And so they are always walking this balance. And I say that as to say that, in the terms of the marathon we're all trying to run together, I do think that the way they're shifting things can have some potential downstream effects that are, beneficial. I think the devil is in the details. And so, it's clear that they've drawn a line in the sand. We're going to put the majority of Medicare patients under an accountable care organization by 2030. And so, that was a bold statement, and it's, and now we're into the weeds of, how are we going to do this and how are we going to make it work? And as you well know, I've been a big advocate for, a lot of specialists, especially cardiology, musculoskeletal specialists, a few others, we really drive, a lot of the major procedures that Medicare has to purchase in this population, and, therefore can really help with the cost issues and, and the Medicare spend overall. And so I've been advocating an appropriate relationship for specialists with primary care providers and trying to lead us forward into this world of value-based care. The latest iteration, they've really just kind of gotten this out where people can really take a look at it. And they have laid out a strategic plan that I would say over, the next 5 to 10 years, if we can, follow through with it, then I've got some hope that they can help us get more to an idea of, of getting value for the Medicare dollar. This first iteration of, releasing what's going to be called shadow bundles has me quite nervous. And so directly as it affects orthopedic surgeons, and mainly because, and they have to use the data. Well, they're going to use the data that they have, and they're going to try to share with ACOs, the orthopedic surgeons in their region, and what their data is like around, overall cost of care, cost of delivery for, lower extremity joint replacements, a couple of other procedures and other specialties. It sounds like a great idea. Like, hey, let's look and help our ACOs identify who the high value specialists are, and then we'll direct patients to them. What's got me worried is because I've been working in this field for a long time. And first of all, using claims data to try to figure out who the high value specialists are is fraught with problems. And, there's a lot of companies out there saying that they can do this and they can help primary care providers find this out. And every time I dig into the weeds with them, I find that, it doesn't at all do that. The data they're using is limited. The algorithms they're using don't really help you identify who is a high value specialist. And I'm saying that because I go down and look, in my own region where I know where, there are certain high value situations and less high value, and the fact that those things don't line up. So that worries me a little bit, lots to learn on that. I don't want to just say, oh, the data's wrong, but using claims data to try and figure it out, and I'm talking about Medicare claims data, is a little bit tough. And then the other thing that, they are limited in this way. So this first release is going to be shadow bundles based primarily on inpatient arthroplasty cases. And so if you've been following the trends over the past, 5 to 7 years, we've moved a lot of the, joint replacements into the outpatient setting, even in the Medicare population. And so you start to get a really select group when you're looking at the inpatient cases only. And then those do tend to be the more expensive cases. And so even if you're doing a really good job and you're actually aggressive with getting as many patients as possible into the outpatient setting, which tremendously helps Medicare in their spend, that's not even going to be reflected. So if you're doing it right, if you're only bringing the sickest patients to the hospital, then your data is going to look terrible. So now I give you this from the, the arthroplasty surgeon's perspective, and we're certainly not the only ones out there, but I'm a little worried that, people are going to get a bad taste in their mouth when we're trying to head in the right direction, but the first pass at looking at this data is going to, it's not going to make any sense. And so I've shared those concerns with them. This is not a, I'm not keeping it from anybody, but when you ask me, like, from the orthopedic surgeon's perspective, I think we're going to have to wait and see. I mean, this is not, our working very heavily with the AOS and our council on advocacy to share these concerns with them, explain and hopefully try to mitigate some of that. But let me back up to say, so that's, in the weeds today. What I do feel like is that, directionally, they are trying to help us head in the right direction. And, what they've professed to say is that in future iterations, we're going to try to create relationships between the specialists and the ACOs so that we can work together to achieve these. And, what I think is important about that is that, our general primary care physicians have a lot of things to worry about on their plate. And being an expert in musculoskeletal disease is not really the main thing they should be concentrating on. So we need to create payment models where the musculoskeletal specialists can handle those parts, where the cardiac specialists can handle their parts. And so there's a lot to learn there. And sorry, that was a bit of a monologue, but just want to kind of get those ideas out on the table.
No, that's great. You've really laid out the problem very nicely there. Let's step back just a second. And can you, just for the sake of some folks that may not be as facile in this space as you and I are, because we lived in it for so long, can you briefly describe the ACOs, what ACOs are, how that refers to like narrow networks for orthopedic surgeons, and specifically, now, are y'all a CJR state, or are you guys just pure BPCI?
No, we are a CJR state, depending on some of the markets, and that's
Sure.
so
Yeah,
it's
depending
been
on
an
the demo.
interesting thing. But a lot of
Yeah.
BPCI players in Texas, especially in the major metropolitan areas, and so some of them rolled into CJR as well. But yeah, I think just to kind of, you're right, I jumped into a lot of jargon, and I appreciate the callback on that. So ACOs are accountable care organizations, and so the idea with an ACO, which actually makes a lot of sense, is to say the people, the healthcare system that takes care of a patient, is responsible for, the costs of delivering care to that patient. Now that can be worrisome if you have, 10 patients in your ACO and one of them, gets pancreatic cancer, then all of a sudden, it's terribly expensive and you can't do it. But if you have a large population of patients, then you can sort of average the care over time, and you can start to get some surrogate of, if you're providing, better care for your patients at a higher quality and directing them to the, lowest cost appropriate sites of care, not over utilizing certain preference sensitive type care items, then you can generate savings. And so, it's sort of paying on a capitated system. So you get one chunk of money to take care of each patient over the course of the year. And if you manage that well, then that is a way to actually, and report on your outcomes, then it's a way that you can be profitable by delivering better health instead of, only being profitable by delivering more care. So it's a step in the right direction. And we're just at those early clunky stages of, how are we going to do it? And our brothers and sisters in the primary care world, a lot of this is, that's where it's going to be anchored, right? The primary care physician is the quarterback of the care, and they call on they throw a pass to the orthopedic surgeon, or they throw a pass to the nephrologist when they need to, but they're sort of responsible for all of these things. And so, in terms of, would you benefit from developing a narrow network? I mean, these things are going to happen sort of organically. As a patient, they have to use a combination of, the region that they're working in, the specialists that they have relationships with in those areas.
Yeah, and define narrow network for us as well.
Well, I mean, I don't know if I'm qualified to define narrow network. I guess I would say that, within an ACO, because let's put it this way, if it's traditional Medicare, that's a little bit different, but within an ACO with a Medicare Advantage plan or some other type of insurance network, you can sort of specify, which providers people can be sent to. I think in the ACO model, it's more, the primary care doctors are going to be deciding who they refer patients to, within reason. They can't send everybody to somewhere in California or somewhere in New York. If you live in Texas, there's obviously some regional biases there, but they're going to be able to hopefully try to control their specialist costs by referring to high value specialists. And that idea makes perfect sense to me. It's just what I was mentioning earlier. I'm worried about, we don't seem to have the right data to really identify high value specialists right now. And, I think that's where we need to get to, or use a payment model where it's not their job to identify the high value specialists. Those who are, working in high value models are going to be much more interested in taking on, the risk and sharing the risk with the ACO. So those are the kinds of relationships I'd like to see them develop. I don't know if that answered your question.
Yeah, no, that's great. So bundles are very intriguing, and it's also interesting that, to varying degrees and with different fervor, both the Democratic and the Republican parties tend to like bundles. I'm not in any way, shape, or form saying they have the same message, but it's one thing, at least in concept, that they do like to participate in, to one degree or the other, to one flavor of the other. So that can kind of survive changes in administration, and that would move forward. And you and I have had calls with CMMI, or the Center for Medicare and Medicaid Innovations, about bundled payments. So what are your thoughts of bundles? Number one, if you want to talk about mandatory versus voluntary bundles, and what bundle payments are to folks that may not know. And then number two, where do you see that going in the future in terms of Medicare initiatives, in terms of bundle payments for? And we all got to admit, total joint arthroplasty is the ideal procedure in orthopedics for a bundle. It's certainly a lot better than any of the trauma stuff I do. Right. So what are your thoughts on that?
Sure. No, absolutely. I mean, that I could do 2 hours on that alone, but I'll try to bottle the essence to some degree. So just in terms of a definition, a bundled payment, let's say it depends on what you anchor it on, right? So in general, when people say bundled payments, they mean, for a procedure, or they mean a bundled payment for a hospitalization. So it's some idea that there's going to be one pot of money that is applied to, a patient for some reason. So in our world, bundled payments for, total hip and total knee arthroplasty are the ones that we talk about the most. And there are some surgeons who will tell you that this is the worst thing in the world or whatever. I mean, I've really watched the whole evolution of this. In some ways, it has helped us to become much more organized. So lots of things that, from the evidence and other things, we had good reason to put into play, but we had financial disincentives. It was more work to try to find ways to get your patients safely discharged home. It was scary for us to start moving joint replacements into the outpatient setting. And there were certain, innovators who were doing it for their own reasons, but you couldn't sort of move the market. And so what bundled payments allowed us to do, which I have always been very excited about, is the surgeon working together with their patients. We're making the decisions on where to help spend those resources in order to help them get the best outcome, and financially incentivized to create savings. I mean, if you really want to decrease the overall spend on a procedure, then you actually have to get those people at the table. And that's one thing that procedure-based bundles allowed to happen. Now, there were voluntary opportunities, and obviously those people who wanted to participate in it and were most willing to standardize care, reduce costs, and get rid of non-value added care, jumped into that market and did very well on it in the beginning because the voluntary bundles made sense. And the landscape was such a mess that there was a lot of low-hanging fruit. So, if your post-acute care usage was way too high and you could easily change that, then that's a great way to save a bundle of money on delivering a population of joint replacement patients. The mandatory bundles obviously were, well, I don't know, obviously, but I think part of the hope with the mandatory bundles was that you'd force others to participate, but it also, it put the hospitals kind of forced them into the driver's seat on some of this, where the voluntary bundles were more, other conveners could be involved. The mandatory bundles really forced hospitals to kind of tee that up and run it. And that, depending on the relationships you have with the people you work with, in terms of surgeons and post-acute care centers and everything else, sometimes that went well, sometimes it didn't. If you look at the post hoc analyses that were done on a few different papers, they found a couple things that were somewhat surprising, right? So everybody was worried that there would be a lot of cherry picking and lemon dropping, patients that were going to be a big problem, nobody would touch them, or we'd only do the patients who were, healthier or whatever. That really didn't turn out to be the case. So when you look at large populations, it turns out that joint replacement surgeons are pretty good people, and we want to take the best care of patients, and we took care of everybody. So the comorbidities didn't really change, and the types of patients we were taking care of, in large studies didn't really change. So that was one, kind of dispelled that myth. Overall, it did save a little bit of money, not a ton, not as much as you might have thought, but at the same time, in a market where the cost is generally going up, for the cost to go down over a couple of years is, a pretty profound difference. So all of that to say is as a preamble to say, I don't see them going away from this type of payment model. I mean, why would they? They're in a world of, having more and more patients coming onto Medicare, and not having a super big increase in their budget. So they got to find ways to reduce costs. I do imagine that they hopefully will be more interested in some of the things that we've presented to them, from some of the payment innovators and, from the AOS actually, to think about, condition-based bundles, or trying to not just take the procedure itself and bundle those costs, but actually think about, who actually cares for osteoarthritis. I mean, our primary care doctors help out with it a little bit, but most of it is handled in the musculoskeletal care world, and a lot of it by orthopedic surgeons. So, can we actually incentivize the system to reduce non-value added care, and at the same time, when you are going to do a joint replacement, let's make it as efficient as possible. So those are the kinds of models that we're hoping that they can move towards in the future, because it creates an opportunity for the ACOs, the accountable care organizations, and the specialists to interact together. I would be remiss if I didn't say that a lot of the early adopters of the voluntary bundles have now opted out. So they're saying, as one of the things that happens with bundles is you get that price down, and then, the next year they'll ratchet it down a little bit more and ratchet it down a little bit more. This, so-called race to the bottom. I mean, I think some of that, has certainly can happen. Or, if you squeeze if there's less juice to squeeze, then your ability to create, shared savings can kind of go down on procedure-based bundles. So, there's some mixed bag on that. But from a Medicare perspective, I mean, that's not really the issue. That's more from the orthopedic surgeon's perspective, or the delivery system's perspective, is that the leaner you get, then the less you might get in subsequent years. And so I do think, that's been our advice to Medicare, is to say, hey, we're helping you here. But if you're going to keep ratcheting down the prices to the point where we can't deliver, we can't cover the costs of delivering the care, then obviously we can't participate. So how do they, find a different way to look at that in the future, appropriate inflationary adjustments or that kind of thing to understand it. So there's a ways to go on that. And then the one big thing I want to mention, Doug, that I didn't about the problem with procedure-based bundles, if you believe, and I think the evidence is pretty strong, that, things like arthroplasty are preference sensitive. So I would say that sometimes people would argue that we might be doing joint replacements on too many patients, right? Or maybe not everybody that got a joint replacement really needed it. And so, that we can debate that all day. But if you believe that to be true, but you pay on a procedure-based bundle, then there's still a very strong financial incentive to do as many procedures as possible. So that's where, payment models might need to evolve so that, you and I get reimbursed for the decision making that we do around surgery, right? Which is really, what I try to tell my trainees is I could teach anybody how to operate. I'm trying to teach you when to operate and who to operate on. And so, if you only get paid for doing the procedure itself, then all of that, intellectual work and the really important judgment calls that you have to make about surgery, you don't get any kind of credit for that. In fact, you're sort of disincentivized from making a good decision about your indications. And so that's why I think we need to have evolved models of bundled payments where you can get credit, appropriate credit for the work that you do and appropriate indications.
So you were talking about these procedural based bundles, but y'all have a condition based bundle as well, right? Which is a really different way of looking at the whole issue.
Right. And, and because I happen to be the one on the call, I don't want to sell it to anybody, but I would just say that, we have had an opportunity down at Dell Medical School in Austin to, try to help pilot the next generation of bundle type payments. And so we have set up a bundled payment around the whole condition. So basically, once the patient is referred into the musculoskeletal practice, we take one payment for all the care that we're going to provide the course of the year. So whether they, end up, doing physical therapy, whether they end up doing injections, whether they end up having, surgery, whatever imaging we do and all of that is bundled together in one payment. So that allows us to say, all of a sudden, if we can provide, excellent care and create good outcomes, but spend less resources while doing it, then we have the ability to create a margin in doing that. So that is the way you would think about incentivizing really high value care. It also allows you to behave a little bit differently. So, we talk about preventative care a lot. It's very hard to deliver preventative care because there's no reimbursement in the world really for that. And insurers aren't even that interested in it because they're worried that they spend all these resources on preventative care and then the patient rotates off their insurance. So I hear that argument a lot. Whereas, if you're getting paid one thing at the beginning of the year, you've got the time to do preventative care with patients. It doesn't hurt my feelings if the patient says, hey, you want to try physical therapy? Or, but if they come in and say, hey, I want to try these, platelet-rich plasma injections that the evidence doesn't really support and they're very expensive, it allows me to take that time to have the appropriate conversation with the patient to explain why, hey, I don't think the evidence is really behind this yet, and so it's not something that we're going to do here. So it really incentivizes that, sticking to the evidence-based care pathways, sticking to the clinical practice guidelines and, and getting credit for doing that work instead of, truthfully, the system right now is kind of set up on the altruism of the physicians and providers who are making the decisions. I mean, if we just behaved according to our financial incentives, then we would do everything to everybody, right? And that's, of course, we don't do that as physicians, but, it's kind of against our financial best interests. So this is a way to try to align the incentives of the people delivering the care with the people receiving the care. And so I think condition-based bundles are a great way to do that in certain areas. There are some other models that are being tried in other places as well.
And you were talking about all the juice, the great MBA phrase, right? All the juice being squeezed out of the grape, such that we're pretty much close to the bottom on a lot of these procedural based bundles in terms of the money that's left to be saved. Because a lot of the post-acute care, for those of y'all who don't know what that is, that's doing a total joint arthroplasty and sending your patient to a skilled nursing facility or a rehab center rather than doing it as an outpatient, having them go home and either doing their own therapy or doing therapy on an outpatient basis. So my point being is that if we're pretty much at the bottom of this and the money has been out of it, what are your thoughts about the future of shared savings? How much more money could Medicare share with the physicians in terms of savings if all the juice has been taken out?
No, that's a great question. And so I would say I don't necessarily want to say that all the juice is gone, because we're still not delivering, care as efficiently as we could, and there's still a lot of things that can be improved. But it is interesting how quickly, if you put a bunch, in the case of total joint replacement, if you put a bunch of orthopedic surgeons to the job of creating more efficient care for our patients, then we do that pretty fast. And we make the moves, and we're pretty influential. We can set up things that work. And so, I'm really, really proud to see, what has happened. It's not, we haven't all shifted to, outpatient joint replacements for the appropriate patients, because we're not really, I mean, some cases you might have a financial incentive to do that, but a lot of it has been that it's a better experience for the patient, the appropriate type patient. It creates more room in the hospitals for the right patients, all of those types of things. So, it allows us to sort of do the right thing and not be, financially disincentivized to do it. But, that said, it would be nice if we get to a place where, the price that you pay for, a bundle of care over a period of time is sort of, somehow reflects the cost of delivery, rather than it being the total shell game of, if you help save us some money, we'll give you some of it back. Well, what if there was just a price for delivering this? And, just like any other type of industry, if you can deliver a better product at a lower cost, then you are the most successful. We don't have anything that looks like that. And we're not making widgets here. We're not making, Model Ts, but at the same token, there are certain things that we do where, standardization would be key. And, I get sort of made fun of by some of my, joint replacement colleagues or whatever, but I often, sort of make the joke that if we were being reimbursed on a system that looked like that, I wonder if we'd be so inclined to start using robotics in all the procedures, if we would be so inclined to, to push some of those things that are more up out on the, the edge of innovation as quickly as we do. But we work in a system where, the incentives don't quite line up directly to the cost of delivering care. And so those types of innovations can sort of happen without the cost being passed down. So I think it would change our behavior. And I hope that example is not too controversial, but I've talked to many people about it. I don't think I'm the only one that feels that way, but it's an interesting question. Can we get those behaviors to say, hey, we want to embrace technologies that actually improve people's outcomes. We want to embrace technologies that actually reduce the cost of delivering care for our patients, but we don't just want to embrace all these technologies just because they're brand new. That kind of behavior it has a lot to do with the costs that we're spending per capita overall.
All right. For the next question, you are the Secretary of Health and Human Services. You're not accountable to any president nor Congress. And your only task is to develop, for orthopedic surgery specifically, the best Medicare system for 10 to 15 years from now. So that's your only task. You don't respond to Congress. You're not accountable to anybody. You're the king of orthopedics and Medicare for 10, not for the immediate future, but you're building the system in the future, 10 to 15 years from now for Medicare. Obviously, that's going to comprise a significant amount of arthroplasty, spine surgery, and trauma more than anything else, right? And then, of course, all the other stuff as well. But those will be your big payers. I've given you a second to perseverate on that. What's the answer, Secretary Koenig?
Yeah,
the Honorable Secretary Koenig.
Yeah, Dr. Lundy, I don't have the answer, but I do have some directional. I have some directional ideas. So I think a few of the things that that I would want to do is to, and you've heard me, I've already said it a couple of times in this conversation. I want to align the incentives of the. And I'm hesitant to say just physicians. I mean, we work in a complex system where a lot of different people are involved in providing care for patients. But, you did make it specific to orthopedic surgery. So what I would say is that I want to get to a place where our incentives are more aligned with the incentives and outcomes of our patients. So, we're at a place right now where our incentives are in this one pile, and in the patient's outcomes, I hate to say it, but they're almost uncorrelated. We don't get reimbursed differently for providing better outcomes. There have been some attempts to do that, but I just wonder, how much better our system could be if that was the case. If you do a better job at a lower cost, you are the most financially successful. So I don't want to make a panacea out of condition-based bundles, but at least in, musculoskeletal care, and it doesn't just have to be orthopedic surgeons, but there are areas where we could do that. I think it's very reasonable to take financial risk on delivering a year's worth of, knee arthritis care or low back pain care or, even hip fracture care. Now, some things get too complicated to really do it that way. So I'm not, I'm not Pollyanna, but there are some, buckets that we could put together and then allow the people who want to be in the business of delivering that care very efficiently and measuring their outcomes and reporting them back to be able to embrace these models. And I say that because I think about our primary care colleagues. I work at a medical school. I will tell you that in medical school, if you're not, in orthopedics or in, physical medicine or a couple other specialties, the amount of exposure you get to musculoskeletal care is almost minimal. It's 1 or 2 lectures in medical school. And then, in the accountable care organization, or even in the old HMOs, you're expecting, the primary care provider to provide a lot of the musculoskeletal care, which is like, how are they going to learn that, right? They're trying to learn it on the job. And so I think there just needs to be an acknowledgement that our specialties and these diseases have gotten so complicated that it requires a specialist. And so we have to have, a specialist model that allows us to take financial risks so that we can yield financial rewards. Or otherwise, we can go the way of, cardiac surgeons, which is to say that, you're over in a corner and your job is just to do these set of procedures, and you don't, you just become a pure technician. Some orthopedic surgeons might want to do that. I don't want to be. I love doing surgery as much as the next person, but the time I spend with my patients, the decisions we make about surgery, the care we provide for their families, the lifetime of care you provide for joint replacement patients, like that is all part of the deal. And it's the part of what makes us great at what we do. So I want to work in an incentive model where, I'm incentivized to do a better job, but also pay attention to what I'm spending on it. And, some of the things I do really, fit that model. So maybe it's self-serving to some degree, but I think that is a way to get us on the road to financial sustainability. I don't think we can just keep providing, spending ungodly amounts of resources and not delivering on better health outcomes and expect that they're going to let us just keep doing that. So I want these changes to happen by physicians instead of happening to physicians. I think you've heard me say that before.
That was outstanding.
Oh, thank you.
This has been an absolute pleasure, and I've really enjoyed talking with my friend, Dr. Karl Koenig, out at Dell Medical School in Texas, specifically about the future of orthopedic surgery and how it pertains to changes in Medicare. Karl, thank you so much for being on the podcast.
Oh, my pleasure, Doug, and thank you for having me. I really appreciate the opportunity to share these opinions with you and talk about what are really pivotal issues for our profession as we're going forward. I would reassure the listeners that we're those of us who are working on the advocacy front are out here trying to make sure that the delivery of care for our patients by orthopedic surgeons is going to be protected in the future. We have to evolve into some of these new payment models and that type of thing, and so that's why we're so dedicated to doing it. I would be remiss if I didn't say that these are really my opinions. There are others that may have some other opinions. I just I want to see a future where we have enough healthcare resources to help take care of our kids and our grandkids, and so that's kind of the direction that we're going. So I wouldn't say that everything that Medicare is doing, we should be supportive of the things that make sense, but we really should partner with them as we have been to make sure that things are making sense as they come out and try to help them be as successful as possible as they roll this out.
Yes, sir. Very, very nicely said. And y'all stay tuned for future episodes in the future of orthopedic surgery on this AOA podcast series.